Hi, hello, Otis Toussaint here, trying to come with you again on another panel for the virtual AUSA conference. We're here with uh, three dignified guests, and today's panel discussion will be in regards to behavioral health and the Office of the Surgeon General's response in regards to the new reality, the new world that we're living in. I'd like to go ahead and have each of guests on my panel introduce themselves. I'll put it together in the large group, and here we go. And we've got first up Dr. Charles HOGE.
Hi, I'm a senior scientist and psychiatrist at the Office of the Army Surgeon General. I also work at the Walter Reed Army Institute of Research. So nice to be here today.
All right. And next we've got Dr. Chester Jean.
Hi, good afternoon. My name is Lieutenant Colonel Chester Jean. I'm grateful to be here today to be able to talk about some of the great things that we're doing within Army Medicine's Behavioral Health Service Line. I'm currently the Deputy Chief of the Behavioral Health Division here at OTSG. Glad to be here.
Awesome. And we've got one more guest, Dr. Ricky Martinez. We will have him introduce himself at a later date. But as of right now, I'd like to have Dr. Jean go ahead and present us with this good information that you have for us, sir.
Great, yes, Mr. Toussaint, you can probably bring up the slides and I'll walk our viewers through some of the key points that we're hoping to share with our audience today.
Okay, here we go.
All right, we can go to the next slide. So our goal today in the next 40 or so minutes is to provide an overview of what we're doing within the behavioral health service line in support of our soldiers and family members. It's a top-level review of some of the efforts that have really been underway for the past decade or so, continuing to be refined over these past several years of the behavioral service line really coming into development here at in the U.S. Army Medical Command. I'll go over some of the priority efforts in terms of what we're doing in collaboration with other agencies, which really is a crucial takeaway that I'll be coming back to a couple of times. Early detection being of foremost importance in terms of identifying behavioral health problems early. I'll then provide an overview of some of our standardized care delivery platforms. And then I'll be handing it over to our Deputy Chief of the Family Advocacy Program, Dr. Ricky Martinez, to elaborate on some of the work within our Family Advocacy Program that is in particular vital in support of family members who are certainly under unique stress under COVID-19 conditions. And then we'll have an opportunity to touch on questions where I anticipate we'll be focusing more on COVID-19 related modifications to how we deliver care, which I expect those will be some questions that we receive, and Dr. HOGE will be able to elaborate in those areas. Next slide, Otis. So over the past, hard to believe, 19 years since 9/11, the Army has invested heavily in how we support behavioral health within our soldiers, within our family members, and on our installations. We've, over those years, developed and refined programs, developed and refined processes to ensure that we're leading forward in not just helping with direct care, but ensuring that we're appropriately integrated with other helping agencies that are there, also in the end to support the well-being of our soldiers, the well-being of our families. The same strategy and the same methods that we use to help soldiers, to help family members on a day-to-day basis over the past 19 years of unique strain and stress on the force directly applies to what we're doing in support of soldiers, in support of families under these unique pandemic conditions. The stressors that have been there are still there, and certainly there are now unique additional stressors on families, whether it be spouses who have struggled with employment given the pandemic considerations, whether it be our healthcare providers, whether it be our forces that have to be innovative in getting the mission done, getting the necessary training done, or just the day-to-day ongoing stress of the news that reminds us that we're really under unique threats on a day-to-day basis with the fatality rates, the infection rates. It's hard to really describe the impact of stress because it just affects every facet of our soldiers, of our family members' lives. The reality, though, for our soldiers and family members is that they have been under unique stress for the past 19 years. So I think that has positioned us in a really optimal position to be able to respond. Next slide. A core tenet of what we're doing within Army Behavioral Health is collaboration. It's the Army. We know no one could do it alone. We're an organization that strength relies heavily on how we connect with our peers, how we connect with other agencies, how we are coordinating and how we're integrating. So there's really no difference with regard to how we conduct operations on a day-to-day basis within the behavioral health service line. At the installation level, we're actually just right now as we speak, that we're conducting a training from our MEDCOM headquarters to our installation leadership within behavioral health on every installation, highlighting and reinforcing the importance of coordination amongst agencies. Behavioral health is really a common endpoint, but that's driven by multiple stressors, whether it be financial stressors, primary care medical challenges, spiritual challenges, the stress of moving, the stress of parenting, the stress of adjusting to homeschooling. Really, there's a myriad number of stressors that certainly behavioral health can help with if the impact of those stressors becomes significant enough to significantly impact social or occupational functioning. But there's many agencies on our installations that are there for the same purpose of helping soldiers and helping well-being. So one priority we have is to ensure that we're optimally collaborating with our chaplains, with our one-source resources, with our Army Substance Abuse Program. We have the extremely really critical support that's offered by our military family life counselors that provide preclinical counseling support, very similar to our one-source resources. And then, of course, their child and youth and school services is integral part of helping families with regard to managing the responsibilities of parenting, of education. So a core part of what we do is collaboration and connection with our other agencies that are really there for the same ultimate mission. Within that, as reflected by this slide here, is the support that we all provide in terms of the community of supports that's present on installations to the unit. The unit commanders, the first sergeants, platoon sergeants, company leadership, ultimately they're the ones who are there with our soldiers for the nearly the remainder of the 167 hours of the week, where oftentimes behavioral health with the most intensive outpatient treatments, generally it's 1 hour a week. So we heavily rely on empowering and working through our unit leadership on collaboration, on ensuring that the environment that the soldiers are living in are optimally conducive to their healing when they need that healing. Likewise, we provide direct support to families, which are really the critical foundation in which our soldiers are developing or residing. Next slide. When, however, problems escalate to the point of requiring direct clinical care, our priority there within the behavioral service line is to ensure that we're detecting problems at the earliest opportunity. In order to enable early detection, we have multiple screening points within the soldier life cycle. We have deployment health assessments, whether it be the pre-deployment health assessment, post-deployment health assessment, in-theater health assessments, which I did note here, but certainly is also a part of screening that is conducted within the Department of Defense. We have post-deployment reassessments where we're evaluating how folks are doing 3 to 6 months after deployments. We have our annual periodic health assessments. And even within primary care, we have actually behavioral health providers, our behavioral health consultants who are working hand in hand with our primary care providers, both in facilitating screening, but then also helping with management and treatment of conditions that are optimally managed within the primary care setting. When soldiers transition, when they PCS, there's a behavioral health in-processing checkpoint where soldiers will stop by behavioral health and ensure that if they're in care, they have appropriate care in the receiving station. When soldiers arrive at the receiving station, we ensure within the behavioral service line, if they were in care, that they have adequate follow-on care. Just this morning, when Major General Crosland, our Deputy Commanding Officer within U.S. Army Medical Command, she shared when in one of her recent permanent changes in station, she likewise had to stop by behavioral health and answer a couple of screening questions. We ensure that all soldiers, really from the lowest ranks to the highest ranks, actually go through these routine soldier life cycle checkpoints. And then finally, upon military separation and or retirement, we also have screening points at that point in the soldier's career. Next slide. Just another slide just to highlight the relevance and why we want to detect problems early. Oftentimes in behavioral health, not unlike many other medical problems, when you identify problems early, oftentimes they exist in a mild state. As those problems persist, they can oftentimes escalate, become more complicated. That complexity can lead to more intensive required treatments, longer duration of treatment. So really, for lots of reasons, we identify problems early, ideally when they're in a more mild state, whether it be depression, anxiety, which I sort of noted there, post-traumatic stress. All these conditions exist on a continuum from a more mild state to a more severely impairing state. So those screening points that I just went over enable that early identification. There are rare conditions such as schizophrenia. I didn't know certain types of more severe mental illness like bipolar disorders that can be more severe when they first arise. However, typically we're seeing problems that very much can be identified at a point where it's early, where it's mildly impairing and treatable on a fairly achievable timeline. Next slide. When we identify problems early, soldiers will then enter into one of multiple programs that make up the behavioral system of care. Over the past 8 to 10 years, our U.S. Army Medical Command, with successive strong leadership within the behavioral health lane, have refined programs that inform on how we manage soldier and family member care. Really, some of those individuals who've contributed really impressively amazing efforts to these developments have included Dr. HOGE, who we're fortunate enough to have on the line here. But I'm just going to touch on a few of those programs, not necessarily going into depth on each one, but just a few of the programs that really stand out with regard to what we're doing for soldiers, what we're doing for families. I already mentioned that we have behavioral health providers within primary care clinics. That's the first one there on the top left. That's a program we call, there it's noted, behavioral health in patient-centered medical homes, or primary care behavioral health. That's a program where we locate behavioral health providers within primary care clinics, and they help manage medical conditions like high blood pressure, like certain types of pain that have oftentimes a psychological or a behavioral health component. So the consultants in primary care help with managing those medical conditions that have a behavioral health component, but they also identify depression, anxiety, insomnia that can respond to really a short course of treatment that can be offered right there in primary care. The next program I'll touch on is the child and family behavioral health system. There's a national shortage of child and adolescent providers. One of the innovative ways that we've tried to really magnify the impact of our individual child and family providers is having them both see patients directly, but also provide a consultative support and enable a relationship where they're training our primary care providers in managing conditions like ADHD, managing conditions that are mild and treatable through primary care. But then those same providers also provide direct care with time-limited treatments within the departments of behavioral health. Furthermore, the child and family behavioral system in many schools throughout our installations have providers actually who are co-located in those schools to facilitate care at an early point for children within DoD schools on installations. I also highlighted there the Family Advocacy Program. That's a program that Dr. Martinez, again, will be elaborating after I go through a little bit more content here. Embedded behavioral health, that's become a sought-after program because it's a program that supports soldiers who are in operational, who are in deployable units by either aligning providers to units or in many cases having the embedded behavioral health clinics actually co-located within unit areas. The vital piece within embedded behavioral health is that it prioritizes and builds upon provider command relationships that oftentimes enable more effective care. As commanders, as unit leadership are aware, certainly not of the details of a service member's condition, but aware of what they can do to help service members, it greatly can facilitate that care. And furthermore, as commanders know providers, they're able to help with that early identification and refer soldiers to care at the earliest point possible. Again, not going into all the programs, but it's a full range of programs from outpatient care through residential care for substance use disorder programs. Next slide. The one other program that I wanted to highlight, which isn't a specific clinical program like a specific outpatient care program, but is a part of all of our outpatient care programs, which is substance use disorder clinical care. The main point that I want to highlight here is that over the past few years, when the Army identified an opportunity to improve how we manage substance use disorder problems by relocating treatment for substance use disorders into the behavioral system of care, Army leadership acted. Over the past, really between 2016 to 2019, there's a gradual move of all substance use disorder care providers from the Installation Management Command to the U.S. Army Medical Command to be co-located with behavioral health providers within outpatient clinics. That enabled unique multidisciplinary care for soldiers with substance use problems, which oftentimes are accompanied by conditions like anxiety, like depression, that can be more effectively managed in a collaborative relationship with the substance use provider and behavioral health provider who's managing other comorbid or combined conditions. The other innovation and significant achievement within Army medicine in the past few years has been changing how we manage substance use problems. Again, going back to early identification. Historically, substance use problems led to a required command notification, and ultimately, if a soldier had any degree of substance use problems, that they identified a required command notification. In approximately March of 2019, the Army changed that policy to enable voluntary care. That's led to soldiers identifying problems early, seeking care early. And as I noted earlier, seeking care early means identifying problems in a more reversible state. Given the high prevalence of substance use problems, this change alone really has been thought to been associated with significant improvement of deployability, of readiness, and of soldiers willing to access behavioral health care. So those are the main programs that I wanted to highlight. And I believe our next slide goes over the Family Advocacy Program, and I'll turn it over to Dr. Martinez to highlight some key points on the Army FAP program.
Okay. Dr. Martinez. Is he available? Dr. Martinez? Okay, we may have some connectivity issues going on there in Dr. Martinez's slide, and that's no issue. More than anything, sir, would you be able to, I guess, since his connectivity is not working out quite well. Oh, is that him? Okay. I think because of his connectivity issues, sir, I'd like to have you continue on and present that information if that's possible.
Oh, absolutely, yes. Dr. Martinez is our deputy chief for the Family Advocacy Program. So really, I think if he's able to join us, he's been intricately involved in all aspects of the FAT program. But I will highlight a few points. Our FAT program is a program it's a required program. Congress requires it. But really, I think the key point is that it's a crucial program. As a child psychiatrist, I have direct experience of the importance of the Family Advocacy Program being a core program to help families. I think the name of Family Advocacy is uniquely appropriate, as indeed they do advocate for families who oftentimes need support. Oftentimes individuals, children, adolescent patients who are having difficulties benefit from a family-directed intervention, not just an intervention for that child, or adolescent. Certainly a core part of that program is to identify problems early before they escalate to significant emotional, physical violence within families. So our Family Advocacy Program helps with managing problems that may not be at the point of family violence, but nevertheless benefit from early intervention. They have various types of, I think as Dr. Martinez highlighted in this slide here, various types of interventions and treatments that sometimes are based on potential trauma-informed treatments. They provide case management services. They're a program that is closely tied and integrated with command support, as oftentimes if there's more severe family-related challenges, the command support is a vital part of that care. The additional point that I think is relevant here with regard to COVID-19 unique considerations is the FAT program. Our Family Advocacy Program has leaned forward in working closely with the Family Programs Headquarters Office within the Department of the Army, as well as the Department of Defense, to ensure that there's messaging out to commands and preventive supports that really seek to engage commanders and families to ensure that there's, again, early identification or early support for problems that might arise. So if Dr. Martinez joins us, he could probably highlight a few other points that he may have wanted to share. Okay. But I'll go ahead and conclude there.
Let's do a quick switch to see if Dr. Martinez's audio is good to go. Sir, are you good to go? Oh, hold on. I muted him. Let's go ahead and unmute. Yes. Hi, sir. Dr. Martinez, are you good to go?
My mic is muted.
Okay, I think you're good to go now, sir. You're unmuted. Yep, we can all hear you. Go ahead, sir. Looks like we still have some connectivity issues.
I'm Ricky Martinez, and I'm the Deputy Clinical Director for the MEDCOM Advocacy. I'm sorry, sir.
Oh, you're good to go, sir. Keep going.
Department of Defense program, which is designed policy for community response system for aiming specifically at preventing and responding to reports of child abuse, neglect, and domestic abuse in military families. The Family Advocacy Program that exists at every installation are located at every installation that is in the community, coordinated community response with a number of different agencies to ensure that there is some experiences with female treatment. Some of those include on the installation, both the command team, medical and behavioral health, the legal team are on the installation, police, CID, as well as child and youth services, DODIA, where they do exist, and SAPRO, Installation Gate, where we work with both civilian social services civilian law to provide a comprehensive prevention as well as response to our service member is to provide a comprehensive prevention and advocacy and early identification and treatment of abusers, voluntary treatment for expecting and new parents. And what's incorporated in the mission that I just read to you is the MEDCOM Family Advocacy. To execute the mission for the Army, the Department of Defense has funded about 400 for the Army FAP program to deliver the FAP clinical services. Of those 400, about 275 of those are a cadre of credentialed, licensed clinical social workers that are primarily located at the military facility. Report of child abuse, neglect, or domestic abuse is received by FAP. It's taken to the Incident Determination Committee or the Case Review Committee to determine whether or not the incident criteria for abuse as defined by the Department of Defense. Currently, the Army has 10 of the largest installations that are operating under the Incident Committee, and all other installations are operating under the Case Review Committee. One clear distinction between the Incident Determination Committee is that it's chaired by the installation or the garrison, the deputy installation or the garrison commander, and the Case Review Committee is chaired by a chief of family advocacy. This particular process is one that utilizes a standardized research-based decision tree algorithm to determine whether the reports meet the DoD definitions. The IDC, it's in mind, the IDC it's a clinical process to determine whether the incident meets the threshold for rigorous treatment, intervention, and support. In addition to that, I'd like to point out that under the National Defense Authorization Act, Section 1089, the FAP's mission was expanded of juvenile and juvenile problematic sexual behavior, and in specific for the clinical side of the house, it's to provide an assessment and evidence-based treatment for any problematic sexual behavior that is presented and is brought to our attention. So that's just a quick, and pending any questions, I'll pause for the moment.
There aren't. Let's see. Let's shift back to myself. So there aren't any questions pending for this at the moment, sir. Let's go ahead and see. Let's go ahead and show the screen. Really, I guess this is the time where I could possibly bring up some of the questions that we have already sent to us, and we could have a discussion on these questions as well. I'm going to go ahead and pop the questions on the page. So the first question is, how has behavioral health care in Army military treatment facilities been affected by COVID-19? Any one of our panel could answer this question.
Yeah, I'll take that. That's something that we've been looking at pretty closely, and as you can imagine, with the lockdown and social distancing and so forth, we had a decrement in behavioral health care. There was a decrement in care across the board. It didn't just affect behavioral health. For behavioral health, during soon after the lockdown measures were implemented, and in the subsequent months, we've had about a 20 to 25% reduction overall in behavioral health care. But a lot of that was offset by a shift in how care was delivered. So, we're still trying to make sure that care is available, that there are, there are minimal barriers to get into care. Clearly, with the change in the structure of care because of COVID-19, that did affect care, at least for the first few months after those processes were implemented. So we have seen a decrease in behavioral health care, but we've been shifting our care to mostly a virtual platform, so we have a much higher proportion of our care being delivered virtually.
Colonel Jean, do you want to go ahead and answer this question as well?
The one point that I'll highlight is I think one success that we've had with regard to managing behavioral health amidst the COVID-19 stressors has been the fact that we have a very strong connection and relationship between our installation leadership through our regional health commands and up to our MEDCOM headquarters. So I believe one really routine activity that we have, which has at least facilitated our being aware of what type of support was needed to address the unique clinical requirements on the ground, has been we have two items. We have a weekly report from our clinic leadership up through our installation leadership, then through regions and up to us, which we integrate on a weekly basis to monitor the distribution of care within each of those programs that I went over earlier. So we have a very useful assessment on a weekly basis of how much care is being provided via face-to-face, how much is being provided virtually. Those aren't exact numbers, but it allows us to get a good idea of what's happening on the ground. And furthermore, when we've noticed that certain locations were really needing to develop some strategies to maintain and sustain programs like intensive outpatient program. That's a program I didn't go over earlier, but it's a program that heavily relies on groups. We were able to help with evaluating various courses of action, deciding on the feasibility, the safety of doing certain groups in person, and develop strategies to have caps, to modify schedules, et cetera, that would still allow for effective patient care while also maintaining safety and precautions that were appropriate for the pandemic. So that engagement and connection between our headquarters all the way down to the installation across the medical command has been very helpful in allowing responsive support to installations that needed it and identifying best practices where they've existed.
Okay, awesome. So I'm going to go back to here. And so we've got actually two more additional questions as well. So let's go ahead and post it on our page. The first question is, well, I guess the second question is, what measures were implemented to address the impact of COVID-19? Who'd like to take that?
Well, I think probably both of us would have, answers to that, maybe a little bit different perspective. But I think that I'd like to emphasize the very rapid shift to virtual care, which didn't just happen again in behavioral health, but also, there was a shift in virtual care across the system. But for behavioral health care, we've now been averaging about 50% of our behavioral health visits have been virtual, and during sooner after the pandemic started, we were up as high as 70%. So a very substantial portion of our behavioral health visits have been delivered virtually. I think one of the challenges was being able to stand that up quickly and have adequate platforms that people could utilize, and we had to be flexible, quite frankly, in decisions that were made with regard to what platforms people could use to effectively deliver patient care in as convenient a manner, where our therapists were in their homes and the patients were in their homes. So that was pretty unprecedented to be able to move that quickly to stand that up. I think that's been successful. I think that we've had, been able to deliver a lot of care virtually, and I think there's good evidence to suggest that that delivering care virtually is as effective and is generally has as high satisfaction ratings as care delivered in person. You have less no-shows with virtual care, for instance, and sometimes it's actually more convenient for patients to do it virtually than to come in to care. But obviously there are limitations also in virtual care. I also want to mention that we're still trying to understand what the impact is overall of COVID-19 on not just on behavioral health care, but on the behavioral health and the well-being of the force and of service members and family members. And I think the jury's still out on that. General McConville just yesterday indicated, expressed concern that the rising suicide rates that have been reported recently in the Army might be indirectly related to COVID-19. And we've been looking at our public health center, together with Walter Reed Army Institute of Research, researchers have been conducting surveys across the force to look specifically at the impact of care. And although it's difficult to show direct impacts, there seems to be a good bit of indirect effects. Things, as Dr. Chester-Jean mentioned earlier in the talk, things like family members who are losing jobs as a result of COVID-19. So the overall financial impact that can have on families. Military families are in a sense relatively buffered because the service member's career is not impacted in the same way that the family member's career might be impacted by COVID-19. And then also just the changes in childcare and trying to juggle everything with the children at home and schooling at home and so forth. So there are impacts. We are looking at them. We're very concerned by the suicide increases that we've seen recently. But it's, again, we don't have direct information that those were directly COVID related, but I think that it's important for us to keep on looking at that. Surveys will be continuing, and we'll be continuing to look at and measure the behavioral health impact and change the care that's delivered as we need to.
Okay. Colonel G, would you like to touch on that question?
No, I concur with Dr. Hogue. I think that was a great answer, and I think he highlighted some of the key points in terms of the without sort of reviewing it again. But no, nothing to add.
Okay, so I've got a last question here for us, and the question is, what has been the impact of DHA transition on behavioral health?
Yeah, that one I could probably answer. I think from my experience, I've been here in the headquarters for the past few years, helping really inform some of the transition efforts with the DHA transition. Sorry, I'm buzzing here. And I think the one important takeaway for behavioral health as a whole is that the DHA transition really has allowed for the advances within Army behavioral health to be expanded to impact and better the care. Not saying the care within our service counterparts and brothers and sisters was not optimal as was, but I think the innovations that we refined over the decade within the Army behavioral health service line certainly have opportunity to improve on the efficiency and effectiveness of some of the care delivered within our other services. So, I think one key takeaway is that the DHA transition really has enabled a broader impact for the advances within Army behavioral health to impact our other services. And I think that indirectly improves ultimately the care for all DoD beneficiaries. Certainly, there's been the transition challenges. One point is that, but not without mitigation. But one core point is that we've had a transfer of some of our program leadership to directly support the Defense Health Agency. So we've had to really maximize and continue to maintain focus on the relationships and collaboration, which I keep coming back to over and over because it is so crucial for the work that we do. But with DHA having a role in overseeing care delivery within our MTFs, we very much had to prioritize the routine engagements to ensure that we're working hand in hand, and we absolutely have done that. From my view, successfully, but that certainly will require ongoing focus. Leadership, our senior leadership within the DHA, certainly within the U.S. Army Medical Command, have continued to reinforce the importance of our behavioral health system of care in service line programs and processes, and really all we're getting is reassurance that those programs will continue to be supported, indefinitely down the road, as far as we can tell. So ultimately, I think there's opportunities to broaden impact and continue to support, as long as we continue to focus on effective collaboration, which ultimately, from our more junior leaders to senior leaders, is happening. So ultimately, I think we're managing that transition as well as can be.
All right. So, sir, I think, hold on, let me, right here. I think, sir, let's see, Dr. Hogue, would you like to touch on that question as well, or?
No, I think Colonel Jean handled that fine.
Okay, awesome. Let's see if we could get back Dr. Martinez back in the house. Gentlemen, I think, that's the end of my questions that I have listed here for you all. If anyone has any, I guess, closing comments to share for us that we can transition on to the next forum that I've got going on, please feel free to share.
I'll just share. I definitely absolutely want to express appreciation for our leadership here within the behavioral health service line and headquarters down to regions, but ultimately, most importantly, to our providers who are providing care tirelessly at the installation level. The challenge of direct care, of coordination, of that collaboration is certainly no small challenge, but it's been impressive in my experience within Army Behavioral Health to witness and be part of that. I absolutely want to thank our providers, and ultimately, I think we do have a valuable and are grateful to serve a critical mission in support of Army medicine, of our Army, of our soldiers in the DoD. So just want to express appreciation to our providers and ultimately, the commanders too, who are in close coordination with. And maybe the final point is for anyone who's really considering their own behavioral health, want to urge folks to seek care and support from those around them first and foremost, as that really is the most crucial support are your unit team members, are your family members, and then some of the agencies. But then if you feel like you have a refractory problem, a problem that's impeding you professionally, socially, then seek care early. So I'll end with that.
Okay. Let's go back here. And Dr. Ho, would you like to share any closing remarks?
No, that was a perfect closing remark. Just echo what Dr. Jean said. Hats off to everyone, from, in the trenches working in MTFs and behavioral health up to the leadership and also the need, the importance of seeking care early when there's a need for that. I'm grateful to be part of this program too. Thank you so much for hosting this.
Okay, let's see if we could have Dr. Martinez. Let's see if he can share his closing remarks. Nope. Yeah, it's all good. It is all good. Dr. Martinez, I'm sure that he would share his points in appreciation for what we have done today. I really appreciate all you four gentlemen participating in the discussion, a needed discussion to show and highlight just exactly what the Army is doing, even in our new virtual COVID environment. It sounds like we've kind of expedited some of the technology that we were going to anyways, but we're making more apparent more today as compared to, traditionally a progressive move towards using, especially telemedicine. So
we
gentlemen,
had a good example of the technology problem we deal with every day.
we did have a good example, and Dr. Martinez, we apologize to Dr. Martinez and his connections, but we appreciate his participation as much as he possibly could have. And so, gentlemen, I want to say thank you, Lieutenant General Dingle and the Office of the Surgeon General. Thanks you for your medical expertise coming and participating in today's discussion. We're looking forward to, AUSA 2021, where you guys could hopefully come and bring that good information once again to a wider audience. We thank the audience for participating and checking out our discussion today as well.
Thank you very much, Mr. Toussaint.
All right. And so in closing, I want to say to everyone, thank you for participating in our discussion today. Army medicine is Army strong.